genital mutilation, together with and intermittent partner violence. So maybe a brief introduction by the panelists. Maybe we begin with Dr. Rose Wafula. Miss Mary Gathitu. Ruth.
Yes.
Hi, how are you? How are you doing, Ruth? Samuel? Dr. Samuel Kimani?
Yeah, good evening, everyone. Are you able to hear me?
Yes, good evening. How are you?
I'm fine, thank you. Thank you for having me and inviting me into this class and the meeting. I'm going to share mainly on female genital mutilation and the medicalization aspect of it. I am a lecturer at the University of Nairobi. I also carry out this research regarding FGM in a center called Africa Coordinating Center for Abandonment of Fgm, a center hosted at the University of Nairobi College of Health Sciences, which our main aim is to generate evidence that inform programming and policy issues regarding abandonment of FGM in Kenya. And over and above that, we do carry a lot of capacity building for healthcare providers and also community to empower them to be able to participate in elimination of FGM in this country. Thank you very much.
Thank you. I don't see any other panelists. I'm assuming you're the first person to speak today, to do the presentation.
I hope so.
Yeah, kindly, you may begin.
All right, very well. This will stop at the screen, that is okay.
That's very okay.
All right. So are you able to see my screen, my presentation?
Yes.
Okay, very well. So my topic today is positioning healthcare workers as agents of change in ending female genital mutilation and its medicalization. As I've said, I'm Samuel Kimani. I work for the University of Nairobi and also a center affiliated to the University of Nairobi, which main aim is to escalate and cascade the abandonment of FGM. Thank you for having me. I'll go very straight to defining what FGM is and medicalization. So the definition of FGM is derived from WHO, and it entails all procedures involved in partial or total removal of the external genitalia of the female or any other injury for non-medical reasons, including cultural reasons. So the underlying word there is any procedure that involves the external genitalia for non-medical reasons. Okay, and then we talk about medicalization of FGM. What it entails, medicalization of FGM is all the procedures touching on the external genitalia performed by healthcare providers. And here we are talking about any kind of healthcare providers, whether nurses, clinical officers, medical doctors, and anybody who is certified. And it also fits the definition if the procedure also is performed in the hospital, whether in a private clinic, at home, or anywhere neutral, because we know, for example, healthcare providers can actually be called to go to neutral places like in the forest to help in carrying out the procedure. So anything that happens around that, then we call it medicalization. However, the procedure also involves, there are situations where women have been performed FGM, especially the type 2, type 3 Fgm, what we call Inifibration. This is where the external genitalia is cut and closed. Now, when these women are giving birth, then it needs to be opened up. The opening is referred to as de-inifibration. Now, some of the women who go through the opening up, they come back to the healthcare providers for resuturing. Now, that procedure of resuturing is called re-inifibration. When it is performed, we call that medicalization, especially when it is performed by the healthcare providers. So those are the two elements that make medicalization. Quickly, in terms of Fgm, we have what we call the forms of Fgms, also referred to as the types of Fgm. So I'll talk about the type 1, which is considered to be mild. It is also referred to as clitoridectomy. It's mainly removal of the clitoris. Then we have the type 2, which is mainly removal of the labia and part of the clitoris. We call it excision. And then we have the type 3. Type 3 is what I was explaining. Usually what happens is there is the removal of the rabies and then suturing them together so that you have only a pinhole introitus remaining. That is referred to as inifibration. So this may involve the labia majora, the labia minora, and also part of the clitoris. And then we do have the type 4, which is very mild, and it refers to all other procedures that involve manipulation of the external genitalia, and that involves maybe pulling, cauterizing, pricking, among others. And what we see, for example, today, and we are going to talk about that, there is a major shift, or what we call changes in the Fgm and the way it used to be practiced. Most of the communities who used to practice the severe types of Fgm, now they are going to lesser form of Fgm. And we think type 4 is one of the types where they continue performing on their girls. Looking at the prevalence, so we may ask, where does this practice happen? All right. So globally, then we are talking about 200 million women who are living with this practice, and most of them are actually found in Africa. So in Africa, we are talking about 30 countries where the practice of Fgm is found. But also we are also projecting and trying to say what is the risk of girls in terms of can they be cut? So every year we run a risk of having 3.6 million girls being cut, and that is why, for example, the preventive mechanisms need to be put in place so that we can protect more girls from being cut. Now, in terms of where it happens, we do have what we call the Ftm Belt that runs from West Africa to East Africa, and then it spans to the Horn of Africa. So you are going to see, for example, countries like Mauritania, or in the West, Mali, and the countries in East Africa, for example, Ethiopia, Somalia, and Kenya, including Tanzania, and then in Egypt and Sudan. Of course, that is not to say that Fgm is only found in Africa. It's also found in Asia. It's also found in South America. And we also have what we call diaspora Fgm. And this diaspora Fgm is very interesting because it actually is because of people moving out to go look for livelihood in other countries. They move together with the culture, but of course also other drivers come in, including, for example, asylum seeking crisis, like when you have war, people get displaced, and when they go with the practice, or maybe they go because they're already having the cut. Then when numbers are being taken, they form part of the numbers of the women with Fgm. So that is the prevalence globally. Locally, we do actually draw our numbers from what we call Kenya Demographic Health Survey. It is the most reliable data that we do have, and we all know that KDHS is done after every 5 years. The last cycle was conducted in 2014. We had expected in 2019 we would have a cycle. It didn't happen. We had expected another one in 2020. COVID came and messed up the systems. So we are not very sure, probably this year it may happen. So the last KD KDHS data show that among the women 15 to 19 years, the prevalence is 21%. And this is a clear show that Kenya has actually continually achieved decline over the years. It started, the first KDHS was performed, which included the module for FGM, was done in 1998. It captured a prevalence of 37.6. 2014, 21.0%. So we could say there is substantial and significant decline in terms of FGM prevalence. However, when you look at what you call subnational picture, the subnational picture paints something a bit different, because it gives you areas, for example, that have very high prevalence, some of them very low prevalence, but also the picture you get out of the subnational data is you can actually show which areas are realizing very high, very steep decline. And one of them, of course, is Central Province. For example, you will see hello, did I lose you people? Sorry.
Yes, I think something happened a little bit, but can you share the screen again?
Okay, let me do that.
Dr. Samuel?
Yes, I'm trying to present, sorry. Okay.
Are you at the end already?
No, just hold on a minute. Okay. Okay, are you able to see?
Yes.
Okay, sorry for that interruption. I think it was the net. So
no problem.
So that is what we are seeing in terms of subnational picture, in terms of FGM prevalence, that the red areas are actually northeastern, where, for example, the decline has been very minimal compared to other administrative units like Central Province, Rift Valley, and Eastern, including, for example, Nairobi. So when we look at what happens along the ethnic lines in terms of the decline in the number of people with FGM, we actually pick we see substantial decline in communities, for example, Taita Taveta, Kikuyu, the Kamba, the Meru, and the Embu. Of course, the Maasai is also some interesting figures there. Among the Somali and Kisii, for some time it had been stable, but we have started to see some minimal change in the number. And one of the things that we know, for example, these two communities, the Kisii and Somali, a lot of work and intervention programs have been put in place. So the question is, are these interventions effective? Now you see there is the group of others. The group of others is what you see on the right panel. These are the communities that are grouped under others. One of the striking things about these communities, the prevalence is very high, more than 70%. But you realize that if you do the analysis of the evidence that is there, very minimal interventions have been dedicated to this community. So the question is, should we start now refocusing our targeted intervention to these communities to see that we can be able to help them address the issue of FGM? So data analysis is very important, and especially what you call micro analysis of data. So I think that this is a snapshot of what I've already presented. So here you can actually be able to see what you call the big four communities, the Samburu 86%, the Somalis 94%, Maasai 78%, Kisii 84%, quite a bigger number of in terms of the prevalence. However, when you take the Kikuyu community, the prevalence is 15%, but this should not be construed that this is not significant, because when you look at the absolute numbers, the Kikuyu population is very high, and this may translate to be very high number of girls who have been exposed to FGM, including the Karenjin community. So it's very important for us to think about micro-analysis of the data that we have in form of KDHS. Shifting to what medicalization, I would, sorry, that is not counties, it is countries with the highest medicalization. We have Egypt, Sudan, Kenya, Nigeria. The numbers for Kenya and Nigeria look small, especially for Nigeria. Why it is important is because 12%, for example, and Nigeria, the population is about 200 million. That is significant. So these numbers may translate to be very huge number of women who have been cut by medical professionals. In Kenya, the prevalence is 19.6%, almost 20%. But what you see, for example, when you compare the panel that is orange in color and the one that is blue in color, the picture we get is medicalization is on the increase. So the orange represents mothers, okay, who cut the mothers in those years and who is cutting girls now. So you find that medicalization in almost all countries, Egypt, Sudan, and Kenya, it is going up, except some decline in Nigeria. Then the question is who is actually carrying out the practice? So I've already mentioned the 4 countries, but we also have medicalization in other countries like Guinea, Djibouti, Iraq. Those are also countries where medicalization is actually high. So looking at who is cutting girls in terms of the card of healthcare providers, you find a very interesting distribution, especially in Egypt. Majority of the girls in Egypt are cut in by medical doctors, almost 75%. Only 25% is done by the midwives. Now that is quite a big contrast compared to what happens to Sudan, where almost 100% of cutting is done by the midwives. In Kenya, we have a mixed bag of of people who do that. We have the medical doctors, and the nurses and midwives are also there. And that applies to also other countries. And probably maybe the issue, the Egypt situation can be interesting for our discussion as we move forward. Now looking at Kenya, the picture we get is when you look at the girls 0 to 14 years, most of them, 1 in 5 is actually cut by a healthcare provider. And we do have what we call the national prevalence is 19.7. And you find that it's actually declining. So it is high among 0 to 14. It was lower among 15 to 49 years as per the current KDHS. But you also have the hotspot. The hotspot areas are mainly in Kisii County and Nyamira, where the prevalence are actually more than 50%. This is a bit old data, but the current one we know, if you ask, it could be running between 60 to 80%. But we also have other emerging areas like Narok and Kajiado, and also Nairobi, and also Garissa among the Somali communities. So those are what we'll be saying would be the hotspot counties and locations for medicalization of FGM. So specifically, when you ask yourself how many doctors are, what is the percentage of doctors who are cutting girls, as per KDHS 2014, 3.5%. And then the nurse midwives participate in cutting to a tune of 16.2%. Then you see the traditional cutters about 72%. And this is a decline from previous KDHS, which showed the cutting was more than 80%. And we also have others, for example, the TBAs. And we had some people who said they didn't know who did the cutting. Now, then the question is, do we see any changes in the practice of FGM? The answer is yes. One of the changes that we have seen is actually shifting from severe form of FGM to that is type 3 to or type 3 or 2 to type 4 or even 1. And this you find quite a lot, especially when you talk to people from Somali origin. They tell you, we used to do it the pharaonic type. Today we are doing the Sunna, and even other communities also, including medicalization is actually, the medical people are actually doing the Resa type. And then the other shift that we see is a shift to young age cutting. So you ordinarily, most of the community would cut girls for the rite of passage. That is, the girls will be cut and they become of age, and then they are counted to be adults, and probably maybe some of them get married off. But today you are seeing very young girls. In fact, for example, some of them are saying as young as 3 years, between 3 and 5 years. All right. And if you have even some cases like in Kisii, people are telling you, okay, you may be going to talk to girls about FGM only to realize they were cut when they were very young. We also have some communities who cut within the first 28 days. And this is very typical among the Taita community. And then the last is the shift to medicalization, which we have been talking about. So in terms of what factors drives the FGM generally from the community perspective, you hear many factors. Some of them are religious. For example, the Somali community will tell you nowadays they are conducting Sunnah, and they say Sunnah is anchored on the religious belief. But again, when you go to understand what the Quran says about FGM, you find that it is silent. But the hadiths have some stories surrounding FGM. Then marriageability. So, and this is a serious driver. Most of the people will say, oh, if you don't cut your girl, if you're not cut, then you'll never be married. So we think that is a strong driver for FGM. And the other one is social norm. And social norm is, these are practices that are practiced in the community, and everybody is expected to subscribe to. If you don't, then you attract punishment or sanctions. If you do, then you get reinforcement and you receive rewards. And we think this is a strong thing. So most of the people who participate in cutting, they receive corrections, they receive a lot of encouragement from the community members. But those who do not, they get to be discouraged, and some of them even a lot of pressure, including they are told that you cannot take even leadership positions in the communities because you are not cut. So that again pushes that. Then the other one is the rite of passage, and the rite of passage is an old story where girls used to be told you have to be cut for you to become an adult. And we have seen this among some communities in the country. Some of them, for example, the West Pokot, some of them like the Kuria, this is still happening. So the girls are being cut at an older age, for example, between 10 and 14. And the impact of this is once they get cut, most of them get married, and therefore they also get pregnant. So you have all these cascades of challenging issues that we are finding in this country. The others are, for example, the hygiene. For example, people say, oh, uncut woman is not clean, stuff like that. And then aesthetic impact that comes to, that brings an issue of saying, okay, uncut woman is not beautiful, stuff like that. Okay. Then when you look at the drivers for medicalization, we picked a few of them. One of them is the religious reasons, and this is common among the Somali community. We have seen they have called the razor cutting nowadays, which is done by the healthcare providers, the sunnah, and they say once you have done sunnah, then you can go for prayers, stuff like that. So there is some relationship and some linkage to the religious whatever reasoning. Then the other one is circumventing the law, and this is something that all of us get worried about, because we know communities that practice medicalization, this is a way of hiding behind the law. So because we know medical doctors are not going to be reported, healthcare providers are not going to be reported because they hold a very high position in the community. And number three, these girls, when they are cut, they recover very quickly. So some of them, we were being told they can be cut in the morning, and in the evening, they're already praying with their other girls. So the evidence there is going to be challenging in terms of prosecution. So, and then the other one is what we call socio-professional norms. The socio-professional norms is a situation where you have your colleagues as a healthcare provider who are cutting, and then you also get induced into the group, and you get encouraged. And if you don't cut, then you are not okay, and everybody start now shunning even your services. And this is an issue that needs to be addressed. The other one is reduction of health effects that are implicated with Fgm, and we have seen this quite often. For a long time, Fgm has been addressed as a health as a health problem. Most of the people say, oh, Fgm is associated with health complications. So the community have picked this narrative and said, okay, if there are health complications associated with the Fgm, who can be able to sort out these health complications? Then they say it is the medical people who can do that. And therefore they go to the hospitals and they request for people to do the cutting. And for some reason, we know medicalization actually do resolve what you call the short-term complications. But in terms of the long-term and the human rights aspect, it doesn't solve any of those problems. The other one is the healthcare providers themselves are actually, they do share beliefs with the community. So you are coming from a community that cut. So what are the chances that you're not going to cut the girls? The chances are going to be very minimal, because you believe in Fgm, and therefore by you doing that, you are like giving back. You are like giving back to the community, and you are holding that community that it is a good thing to do. Then the final bit, which has kept coming up, is income. Healthcare providers are beneficiary of this practice through the money that is paid by the parents. And we think this is a big motivator to continue doing medicalization. Now, when you look at the impacts of Fgm, they span from immediate complications once the cutting has happened, and you have seen all of them. The complications around the injury that is going to be caused when the cutting is happening. Then we have what we call the long-term complications. So some of them are keloids, some of them are fistula, especially in the extreme cases that we have seen involving gynecological and urinary tract system. And then we have what we call the obstetric complications. Obstetric complications, these ones are very common, and they were highlighted a long time ago by some of the elegant studies that were done by our colleagues in the University of Nairobi, supported by the WHO, Professor Jaldesa, Professor Karanja, which showed that Fgm is actually has a major impact on the obstetric outcome. And some of the issues that were seen is it increases PPH, it increases episiotomy, it increases tears, and generally the stay in the hospital. So basically, Fgm is associated with the poor obstetric outcome. The other two complications, sexual complications, are also seen, and also psychosocial complications. They are actually being reported. But one of the things that we have seen, even in our studies and the research that we have conducted, is this is an area that has been really, really neglected. A lot of women are complaining, are coming out but nobody is helping them. And I think this is, with this discussion, we hope some of the people who are in this audience may pick up some of these issues to try to start addressing and be able to help our clients. So one of some of the impacts that are not well documented, but we know they are there, even the communities are not going to tell you, FGM can actually result in death. And one of the typical cases was a case reported in the New York Dailies in 2013. And this is a girl who underwent FGM and she died. Apparently, the cutting was carried by a medical doctor. And why I'm saying medical doctor is because in Egypt, 95, 75%, 80% of the cutting is carried out by medical doctors. So even after it was done by the medical doctor, the girl died. And this changed the way people are looking at FGM, especially medicalization. So it is something to think about, all of us, that it is not safe to perform FGM for a good reason, because there's nobody who goes to a medical school or even a nursing school or other colleges to be trained to carry out cutting of girls. At least most of us are trained on how to perform male circumcision, but not female genital mutilation. And that is a difference. Okay, so then we ask ourselves, why does it matter then to address medicalization of FGM? It does matter because, one, it is willful damage to healthy tissues for non-therapeutic reasons. The second one is it violates the expectation of health workers to do no harm. So by you conducting FGM, then you are negating that principle of do no harm, and you're actually causing more harm. Then it represents harmful and unethical practice, which has been condemned. The other one is there is no healthcare provider who has been trained to perform FGM. And then in terms of medicalization, even if you do it, then it doesn't resolve the issue of long-term complications, and it doesn't address the issue that you are violating the human rights of that girl or that woman. And then by performing FGM, you are also creating an approval that this is a good practice, mainly because healthcare providers are held at very high esteem by the community. So anything that you do, you know that there are many people who are watching you, there are many people who are behind you, and they will copy you and they will start doing it. And the last one, and which is very important, it contravenes the government's policy on banning any form of FGM. So we have a law in this country which have banned FGM, including FGM done by healthcare providers. So what is the implication for medicalization? So what we say is by healthcare providers performing FGM, then they approve the practice, and therefore we think even the other non-healthcare providers can start even doing it. The other issue is it may lead to total shift instead of abandonment, and this is what we have seen. Most of the communities, like among the Kisi, we have seen a total shift in medicalization, and we haven't seen a decline in the practice of FGM. The third one is medicalization is driven by both supply and demand side. So supply from healthcare providers and demand by the families. And therefore, if we're able to break that continuum, then we are able to address the issue of medicalization. The other one is the normalizing and the modernization of FGM. It is a possible consequence of medicalization. So we need to be careful, because once we think that this could be a new normal in terms of performing FGM, everybody is going to follow suit, and this medicalization will go to full blast into the hospitals, and it will be a dilemma for us to address. The other issue is medicalization presents a dilemma between healthcare providers, because you are guided by the principle of do no harm and the ethics and the morals that you run as a professional. But again, you also being pressured by the community to perform it. So you will need to carry out a big balance and decide not to listen to the community and do what is good in terms of your professional responsibility and accountability. And the last one is the opinion of healthcare providers is key. Being very high in the society, of course, being held at high esteem. Whatever you decide, then you become a very important change agent. And therefore, that is what we need to take up as healthcare providers. Now, we do ask ourselves then, are there strategies or maybe to address medicalization? The answer is yes. We have had global strategies, and some of them are what we call the global legal policies. Of course, the UN legal instruments that have been ratified by different countries, including Kenya, to protect human rights, to avoid any harmful practice, including even the SDG 5.3 do address the issue of elimination of harmful practices, including child marriage and FGM. So by doing whatever we are doing, responding to FGM and making sure that it is ending, we do actually respond to those global instruments. The other thing is WHO itself has actually come up with a strategy. In 2010, it came up with a manual of global strategy to stop medicalization. And I implore on every member who is here, you can actually look at it and you see what are interventions that were recommended by WHO and which we continue to push and maybe familiarize with each and every healthcare provider. And then we have the WHO has also developed tools to support healthcare provider build their capacity in terms of prevention, in terms of management of complications. And these ones have been very handy. Some of them developed as early as 2001. Some of them have been revised. We had a handbook in 2016, and even the latest one is the guideline of 2018. So we do have quite a number of tools that can support capacity building, that can support healthcare providers to be agent of change, and that is why we are having this discussion today. In terms of locally in the country, what are the things that have happened? The latest one is actually what we call the presidential decree. In 2019, our head of state made a decree that FGM must end by 2022 in the ICPD plus 25. And I think all the systems now have been primed to respond to this decree. And that is why probably we are having this discussion today, and moving forward, I think we will continue to involve you so that we can also feed into that decree moving forward. Over and above that, Kenya has had a very conducive legal policy environment, and this legal policy environment spans from the Constitution itself, which guarantees fundamental rights to everybody. We have the Prohibition of Fgm Act 2011. We have the Children's Act 2001. We have the Protection Against Domestic Violence 2015 and the Penal Code. For example, if you carry out a FGM and somebody is grievously harmed or even succumbs, then you are going to be prosecuted under the Penal Code 63, Cap 63. So we would say that we do have what we call a conducive legal policy environment in this country to be able to end FGM. The other one is, of course, the Prohibition Act 2011 established the Anti-FGM Board, whose mandate is actually multi-sectoral coordination of all activities against FGM. When we move to the sector of health, a lot has happened. We had the first reference manual for healthcare providers that was developed in 2007. Maybe some of you may have, you are familiar with it. But of late, in response to what the president has said in ending FGM by 2022, we have seen a lot of activities, of course, from the Minister of Health. We have the Reproductive Health Policy 2020 to 2030. It contains very serious goals in addressing FGM. The Minister of Health also in 2020 issued a policy statement regarding FGM and also medicalization. We had a Minister of Health consultative meeting with the professional bodies so that they can become partners in addressing FGM. Right now, Minister of Health has already developed an FGM work plan, data capture into the into the data system. It has developed training tools that are going to help in capacity building. And we do have quite a number of capacity building initiatives led by the Ministry of Health so that FGM can be addressed. And today's meeting is part of what Ministry of Health is doing through Kenyatta National Hospital. And we really thank you for this. Looking then, what is the way forward? So the way forward would require a multifaceted approach in terms of addressing FGM. One of it is discussions and dialogues with the professional associations, so that professional association can be able to declare medicalization illegal among its constituencies. And this is important so that these associations can be able to highlight what the legal and policy instruments do say about FGM. The other one is we are going to involving regulatory bodies and associations, and this is important so that they can come in handy to try and see how can we deal with rogue healthcare professionals who are cutting girls so that they can stop doing that. And this is important because it looks at a bigger picture, including what discriminatory measures do we put in, how do we sanction some of these people, or how do we even implement capacity building so that people can start to understand from a human rights approach that FGM is actually a health issue and it's also a human rights issue. The other one is training and sensitization of healthcare professionals. And this is part of what we are doing, and and many more programs have been are lined up, including what we do at the University of Nairobi. And then we need also to mainstream FGM in healthcare curriculum and training. And this is something we have already started. We have started to talk to the universities so that we can make sure that all the programs that train nurses, doctors, clinical officers have a component of FGM as an intervention. And then we need to support and participate in FGM monitoring. This is important so that we can be able to know how much medicalization is happening where, so that we can have what we call targeted intervention. And the final bit will be multi-sectoral collaboration. And I think this has already happened. The Ministry of Health has collaborated with an anti-FGM board. It has collaborated with the gender ministry to make sure that we can harness our resources and our synergies to be able to address FGM across board. So in conclusion, what we are saying is healthcare workers are key in realizing the presidential decree in ending FGM by 2022. And of course, other development agenda that are lined up, including the Agenda 4 Vision 2030. And therefore, the call here is for us to occupy our rightful position. And occupying our rightful position is taking this challenge head on and saying that we are going to be change agents to address medicalization. The other issue is medicalization is, although medicalization is on the increase, it is illegal, it is unethical, it doesn't have any medical benefit, and it therefore undermines FGM abandonment. And therefore, all of us as healthcare providers, we need to work together so that we can address it. The third conclusion is it is important for us to integrate FGM into the health program. And here we are saying, for example, right now, as it is, health FGM has been addressed as a standalone whatever issue. So we need to integrate this into maternal child and other programs so that we can be able to leverage on resources and we can be able to move together. And this, we think it is a critical pathway for addressing FGM. The other one is we need to involve professional association, regulatory bodies, so that we can be able to address this among our colleagues, so that we can stop participating in cutting the girls. And finally, intervention with healthcare workers is important. It is important for two things. One, we need to be change agents, and we need to be in the forefront in prevention of FGM, including medicalization. But also, we also have so many women who are living with the complications that are related to FGM. And therefore, what that means is we need to screen them, we need to identify these complications, and we need to mitigate the suffering the women and girls are undergoing. So thank you very much. I will stop there. In case of any question, I'm ready to discuss with you. Thank you very much. Did I hear you or I lost you?
No, you did not lose us. You found us.
Okay, thank you.
Thank you very much for that intriguing session. In fact, the first time when I was hearing medicalization, I was just wondering if I was hearing my own things until you kept on repeating it. And then I'm like, oh, people actually do this. Doctors actually perform these things, and nurses and clinical officers. Thank you for sharing this information. It's an information that a lot of people are not aware about. So we might begin. First of all, probably I don't think we'll be able to do both sessions today. We'll carry forward, Dr. Wafula. We'll carry forward the session on IPV next week. So maybe we just start off with questions and answers on this forum. I can see there was a question somebody had asked regarding FGM in Kisii community. I think we need to do much. That's just a comment. Thank you. Somebody is asking, kindly explain the prevalence of FGM among the Luos.
Okay, so what I would say is in terms of prevalence of FGM, Luos are among the communities in this country who don't practice FGM. I think we have five communities. We have the Turkana, the Teso, about 5 of them, and Luyas. However, if you go to some counties like Migori County, we do have FGM there, and for a long time people thought it was being performed by Kuria community only, but we also have a lot of Somali people who have settled in Migori County who are practicing FGM. The prevalence is almost 100%, but there is also a community that has not been documented for a long time, and we realize they're also cutting the Suba community. There is a Suba community. I don't know whether it belongs to the Luo wider clan, but we are told there is evidence that they are also participating in the cutting. So the few Luos who probably we may see FGM in their land could be the one that are also probably maybe intermarrying. For example, maybe a Luo man intermarry a Kisii woman, and then when the statistics are the numbers are being taken, then it will show that we have some FGM in the rural community. Yeah.
Yeah, thank you. There was a question, Dr. Ruth Omai, she's part of our panelists from COGS. Dr. Ruth, maybe introduce yourself. And there's a question I can see you'd love to answer. What motivates health professionals to continue with FGM practice?
Okay. Good evening, everyone. I'm Dr. Ruth Omai. I'm a consultant obstetrician gynecologist and a member of Kenya Obstetrics and Gynecology Society. So I'm really happy to see one intervention involves including the professional associations to be part of the fight against FGM. I also worked with ACAP and I did a postgraduate study still on the antenatal preparedness and complication readiness among women who had undergone FGM, because FGM is also causes a lot of childbirth related complications, and we wanted to see where, as obstetricians gynecologists, we could offer an intervention. So I'd like, Dr. Samuel covered this very well, but I can also comment on it. Most health professionals continue with the FGM practice mainly because of income, especially retired nurses or retired, even doctors. And because when they're called by their communities, because people started believing that if you practiced FGM in a health facility or practiced by a health practitioner, it made it safer. So communities started asking health professionals to do this with them. And so it drove medicalization. Other things like Dr. Kimani said is that some of our healthcare workers are also born and live within these communities. So it's actually like a conflict between, the cultural norms of that community. So they participate still in those practices. I mean, it's ethically, it is not correct and actually should actually be highly discouraged. And that's where we want to work. We want to work with demedicalization and actually condemn it fully so that we can be able to participate and end FGM. I think I've answered that.
Thank you. Thank you very much, Daktari. I think your introduction was quite interesting. You've done a lot of work on FGM and birth complications. Yeah. So maybe we ask other questions. There's somebody asking regarding, are we able to identify this health personnel who perform FGM medicalization, and what can the bodies do about it? I think you answered it, but maybe we can expound on it because there's a lot of similar questions on that. Any of the panelists?
Is that asking us to answer?
Yeah,
Okay.
there was a time you briefly, yeah, maybe you can expound further.
What was the question again? Sorry.
It's in regards in identifying people who do it, and what are the medical bodies doing about it? Do they consider it to be unethical? Is there a law on it? Do they get punished? Can you de-license them or something? Yeah.
Thank you. One of the things that we know is the community is a bit hesitant to say who is cutting. In fact, in our research, for example, when you go to PC, you'd ask people, say, yeah, we know the healthcare providers are cutting and we know a clinic somewhere, but they will not tell you who it is and where it is. I think that secrecy is what is actually working against us. But secondly, what we could do is to try and pick up this, because we have tried it through research, is to try and involve the community themselves so that the community start to develop a lot of confidence with you as a researcher and the people who are, for example, working to regulate these professionals. So that is how we can be able to get, and of course, the dialogues that we are recommending could actually help, because once we have the dialogue, then even our own colleagues can actually start to understand, hey, we know of a colleague of ours who is doing ABC, so probably we need to start talking to them or even maybe reprimanding them so that they stop this practice, which is also damaging our reputation. So that is where we need to go. As per what is the regulatory bodies are doing, would say nothing much really has happened. But I think from 2020, we have had a discussion with them. And one of the things that everybody got shocked is actually they came to know this is actually happening by their own members. And I think the clarion call that came up and the commitment that came up out of that dialogue is that they are all going to make sure that they put systems in place, that whoever they're going to sensitize their own members, and in case anybody is caught doing this practice, they are going to be reprimanded, including maybe cancelling of the license. And for us, I think, including the government, that has been a very strong statement. The government has issued a very strong statement, and they say anybody who is caught cutting, that is unethical, and the license must be withdrawn. So there are mechanisms to do that.
Okay, thank you very much. There's a question here. It says, why would a woman want to be resutured after being opened up? I think you're the best person to answer this, you and Dr. Ruth. So yeah, any of you.
Yeah, yes. So very quickly, that was what we called re-inifibration, and we call this re-inifibration part of medicalization. we don't know the reasons why they do that, but the evidence we are generating right now, most of them, they get like the push from the family, and they say they are going to lose their husbands if they don't go for resuturing. So, and you know what that means. They say, oh, if you don't resuture me, then the husband complains that I'm big down there, and therefore he's likely to leave me. So that actually pushes the woman to go and she's done resuturing. You can imagine what pain she goes through. So I think here we need to do a lot of awareness creation, including men, and some of the strategies must target men so that they can stop pushing their women to go back for resuturing once de-inifibration has been done.
Thank you, Daktari. I can tell you interacting with these people a lot from the content of what you're talking about, because the Firauni, the Sunnah. I'm a Somali, so I know these talks too well. So thank you for being a key interested person in terms of trying to understand and really relate so that you can actually solve this problem. There's a question. Yeah, there's a question here regarding reconstructive surgeries. A patient walks in the hospital with damaged genitals due to FGM. Is there a way they can be treated, maybe surgically, to regain their normal genitals as before the cut? Any of the panelists, Dr. Rose, Mary, Dr. Kimani, any of you can answer.
Maybe I can comment very quickly. Maybe this is an interesting area, and I think the specialists who are in the house, this is one of the areas that it's an emerging area, especially in this country. In the last 4 years, we had what we call clitoral reconstruction surgery being done at Mamaruse Hospital, and they were being done by one Dr. Aden. I don't know whether up to today he continues with the practice. But basically, the issue here was to try and reconstruct the clitoris, and the women would probably go back to the near normal situation. It's a big business. It's a big business in Burkina Faso. There is a whole hospital that is dedicated for that. In Egypt, in fact, why I was commenting about Egypt is, in fact, what is driving FGM in Egypt is reconstructive surgery, because most of the time the girls would go in the pretext, the women would go in the pretext of construction, and in the process FGM is also performed. So there is also a thin line between some of these procedures, because we don't know what will cost, what one procedure will lead to another one. So we need to be very, very careful. And I think even the regulatory bodies need to be also careful that they can allow the reconstruction of clitoris in women who have been cut, but also make sure that they also prevent more cutting from happening, and especially medicalization. So that is what I would say. In terms of whether that woman would benefit, yes, it is true. They can be able to benefit. And I know my colleagues in the panel should be able to bear witness with that. The only thing is whether the sexual performance will be restored, because sexual issues with women, they are more psychological than physical. And that is one of the debate that goes up there. In fact, when Dr. Aden was performing this procedure, people were asking, are you only restoring the physical clitoris? Are you restoring the psychological clitoris? So that's another debate for another day. Thank you.
Yeah, thank you. In fact, I think Dr. Aden has done even some workshop in KNH. Sorry, Dr. Ruth, you may continue.
Oh, sorry. I think my comment about reconstructive surgery would be, for some women, it may actually be necessary. Remember, like type 3 de-infibulation will actually cause, even the introitus to be scarred, to have a lot of fibrosis. So you might have to do procedures on this patient for her to be able to have some sort of proper reproductive function, like even passage of her menses, and even to be able to be sexually active. But then unfortunately also some of the procedures, some of the FGM is so destructive, it will not allow you to return, her function to fully normal. But maybe in terms of psychological help, like because it will improve maybe her self-esteem because of how, she maybe looks at the vulva. So, but I support what, Dr. Kimani is saying. We have to draw the line between what is proper reconstructive surgery, what is a proper indication, because you also don't want now to create an avenue for health workers to abuse and then end up now performing FGM in the health facilities. So that would be my comment about that.
Thank you, Daktari. I remember there was a time I came across an article by Biko Zulu. He was discussing, he had an interview with somebody who actually benefited from the reconstructive surgery. And it was a very interesting discussion. Yeah. So moving back now to another interesting question. John is asking, what is the legal implication on female adults who willingly want to cut? Have you interacted with such people? What would you say about them?
The nice question. I think the statement here is, and I draw this from the Prohibition of Fgm Act in Kenya. FGM in Kenya is illegal, whether you're an adult or a child. When you look at the Children's Act 2001, it prohibited FGM among individuals who are less than 18 years. Now, what happened? People took advantage of that lacuna, waited until the girls were 18, and then after they are 18, they took them for cutting. And that is what made the FGM become a nightmare in this country. Now, what came to cover that lacuna was the Prohibition of Fgm Act 2011, because it banned and prohibited all forms of FGM, whether on an adult or even in a child. However, in this country, I would tell you without doubt, we have had a situation where women are being cut. You will hear stories, and not stories, it's actually evidence we have collected in Mauche, like Nakuru, women who have had 10 kids or even 3 kids. They have been married for 10 years, and then for some reason, something happens in the community, they start being forced to go for FGM. That is one form of adult FGM. The other form of adult FGM is what you see even among communities that practice FGM, like the West Pokot, the Kuria, and even the Kisii. You hear a woman escaped FGM when they were girls, and then when they are pregnant, when they are going to give birth in the hospitals, the TBAs, or not even in the community, the traditional birth attendants cut them, or even the healthcare providers do cut them. So we have adult FGM happening in this country. So how to deal with that? That would be, we need to come up with a very, very, very serious strategies that can target that. Thank you. And of course, we are also aware about the case of Tatu Kamau. Maybe my panelists can comment about it. It's touching on that question.
No, I don't think, personally, I'm not aware about Tatu Kamau. Maybe you can elaborate further.
Good evening.
Yes, Dr. Rose. Amani Mary. Yes. Yes, Dr. Rose, continue.
So did I interfere with Dr. Kimani's response?
No. You too. You're commenting now.
Yeah, so I just wanted to add to Dr. Kimani's comment on the issue of FGM amongst the adults. As you rightly said, we moved from it being only an illegal practice amongst minors, that is persons below 18, to adults. And the global understanding is that, as mentioned, it's a violation of rights. And the way rights are violated even amongst those adult women, if you look at communities where married women are being pushed to FGM, oftentimes there is an indirect push for them to actually undergo FGM. So you, as you rightly mentioned, in those communities, these women will be treated less important, will be excluded from participation in what we call society's norms. There will be, their children will be less regarded in that community. So yes, she'll come forth wanting FGM, but really it's not voluntary. There is a push that is pushing her to do that, and therefore it raises the concern: is there really an issue of voluntarily wanting to undergo FGM? And then the second thing is definitely it's just an illegal practice. So we cannot say it's illegal, but she wants. The law is the law, and as we are right now, the law remains as it is. And that refers also to the case that was brought forth by Dr. Gathitu. I think it's still in court. We cannot prosecute it here, but the ruling is still awaiting, where she was talking about the need to maybe exclude the issue of wishful FGM and also the issue of why healthcare professionals cannot participate in that. So we can't prosecute it here, it's still in court, but as it is right now, the law prohibits any form of FGM, whether it's conducted by a healthcare provider, whether it's in a child or an adult. And as law-abiding citizens, as part of this country, we live by that law. I wanted to comment also on the issue of reconstruction. I think Dr. Kimani, if you remember, this is a conversation that we had when we were talking about looking at the manuals and the guidelines. And it's a very, as you rightly put it, it has the pros and the cons. Part of the concerns that also are raised, apart from what Dr. Kimani has raised, is that a lot of women who come for reconstruction also think that they may have better sexual experience. And beyond the physical reconstruction, the mental aspect and the other aspects that drive sexual satisfaction has to be considered, because the woman may have different expectations from the outcomes of the reconstructions that is given. So I think it's an area that more discussions are happening and more research is required in terms of what would be the best, how do you select the woman who then requires or who fits to have the reconstruction, other than the obvious injuries that are there that need to be if it's an open injury. And that leads me to the other question that was raised. I think on the questions, there was a concern around the mental health and FGM. This is increasingly a big issue that we think must be embedded in our approach of dealing with FGM. This is because as you have young girls moving to other areas, they then see themselves as different from the others. So they were circumcised at 14, they go to university, they're now in Nairobi, away from their communities, and they look different. And this can have a very serious mental health impact on them. Apart from just the fact that even as we are talking today, now that it's a common conversation in many fora, some of us have undergone, or some of our colleagues have undergone FGM. So the psychosocial support, even within our colleagues and even the clients that we meet, in terms of the mental health impact of FGM, is something that we must bear in mind. We recently saw the elders saying, men in a certain community should not marry girls who have undergone FGM as a way of, addressing FGM. While that may sound good, but what is the impact of that to the girl who has undergone FGM? So even the messaging and the packaging of what we are saying out there has a mental health impact on the survivors of FGM. And a part of what the ministry is working is around putting together packages of messages that as healthcare workers, we can be agents of change, but with factual and more responsive messages that are out there that can be used to address FGM. As Ministry of Health, we consider healthcare workers as partners in addressing FGM, both as champions, but in a way, we are also using a double-edged sword where we are saying, however, you are on your own if you're found. There is no place that the ministry is going to defend you and saying, oh, we're any healthcare worker, so you will protect you from the law. So it's a double-edged sword. And one of the key messages I think Dr. Kimani said, and that is clear from the ministry, is that this is an illegal practice, both from the law of the land and the practice of professionals in health. So one message that must come out from here is that as health, we do not partner in conducting FGM. So you're on your own when you're caught. both from the law and even from the practice of your professional organization. We have already talked to the clinical officers organizations, the nurses, the midwives, the medical doctors. The council is reviewing the codes of practice, and I do hope the other bodies are also looking at their code of practice, so that there are very specific FGM statements apart from what we already covered under the law. So I think for me, one critical message is that this is not a small issue. The minister has taken it seriously because it's a presidential directive, it's within the law, and let's, at least if we can't help those survivors, let's not be the ones that are cutting them.
Thank you very much, Dr. Rose, for that quite informative discussion. Maybe just a comment. I can, apart from being a doctor, I'm part of the population. Somali community is big. I've had discussions with a lot of people on adults actually being more than willing. They're the ones who are actually asking, how can we get the FGM done? So it's actually not just them being pushed. Some of them are educated and they're more than willing to do it. The issue of mental health, you're very right. It's deeply enrooted in majority of the girls. In fact, the questions that they're being asked, like, oh, have you had it done? So they find it to be very, especially when they're being asked by a man who wants to propose to them, they're really suffering quietly. And thank you very much for saying the ministry has taken their mental health very seriously. So there's a question here. Somebody is commenting about FGM. It has no medical benefits and we should be at the forefront to discourage it. However, shouldn't we encourage medicalization? Because discouraging it will take the community back to the traditional performers. So that's a controversial question, but I think a lot of people will be asking the same. Any of the panelists? Any of the panelists would like to answer?
Yeah, I think if I could comment briefly, that's a very valid question. I think all of us are aware about that, and especially in the light of people thinking about health complications and where they could get resolution of their health issues once FGM has happened. But what I would say is, if, for example, we cut the supply, and the supply here I'm saying from the healthcare provider side, if we all refuse to cut the women, what would happen? Probably right now, as I know, if you go to Kisii, the number of traditional cutters have actually substantially decreased. And in fact, you talk to many people, they will tell you those women ceased to exist. And they cease to exist. Now the healthcare providers have taken their possession. So I still think if we remove them and also we remove the healthcare providers, this issue can be resolved. And of course, together with the interventions that target the families, because the families are the ones who decide to go to take their girls for cutting. Yeah.
Yeah, thank you. Another question is it possible? Yeah, sorry. You can make the comment.
I'd like to comment about medicalization. If as health providers, okay, first of all, we're the gatekeepers of health, you know.
Mm-hmm.
If we are seen to be involved in a practice in which we as health workers even have evidence that it is not beneficial to the women, and we're the ones conducting it, I think we also show the community that in that case, it's okay. So as health workers, we should, we're actually one of the government strategies and part of this, fighting FGM is multi-sectoral, and we are part of the sector which is involved in fighting FGM. So us participating in it is validating it and then enhancing the FGM to continue. So I think we should be playing more of a role of condemning it and making sure we don't participate. That way we reinforce the message that we're giving the community.
Yeah, I agree with you, Dr. We should just stick to no, we don't do medicalization of FGM and not send mixed signals or mixed information. Another question is regarding a number. Is there a number to report if we meet any FGM case locally, and can they get fast response? Like a hotline, I guess.
Yeah, I think there are quite a number of them. I think you can use there is a 116, number 116. I think that goes to Childline, and of course we know FGM is performed on children. If you call that number, then you can be helped. And I think we also have the hotspot counties are also trying to establish their own toll-free numbers where people can call when they have seen a child who is at risk or maybe who is under distress and they need to be rescued. So they are, I think probably the ministry should also, we should also liaise with the ministry to see which other numbers can be able to pick up. Yep.
So maybe I can add to that. I agree with Dr. Kimani. And as part of the government, the one government response to the FGM, looking at it from the fact that it's an illegal practice, it requires the provincial administration, the police to be involved, the health sector to be involved. There's an ongoing initiative to provide hotline numbers that are able to send signals to the other sectors so that it's not just one sector that is informed, blind to, and the information is blind to the other sectors. And this is an app that is in development. So beyond having a place to call, there's an ongoing initiative that very soon will be unveiled that would look at having a mobile-based application that can give you a signal that this is happening deep in Samburu, this is the location, and this is and this will be open to the public and to the community around there. Because what has been missing is the response. Apart from people calling and informing that this could be happening, then there is no visibility to the other actors that may be required to come in, either to rescue the girls or also to create accountability to the other partners. So there's that ongoing initiative as part of fast tracking the presidential directive. Other than that, I see a lot of people asking about what if now in the context, if you can't call, like any other form of gender-based violence, report to the nearest police station, report to a hospital that is there. And as healthcare workers, again, one of the expectations is we should be able to examine, document, because this evidence is actually required in court when they are prosecuting this. Eventually it rounds down to what you documented when you saw. So you may see a case being brought to hospital, do not be shocked, examine, document what you've seen, and appear in court and present the evidence. And sometimes they'll be brought by police or the chief. Yes, so those are some of the avenues right now.
Thank you.
I think I'd also like to also add that, okay, we have the FGM, the one that's happening, far within, in the bush or far away from you, but there's also FGM happening right next to you. You could be a theater nurse, you could be a doctor in a facility, a clinical officer somewhere in another facility, and you know someone who is actually performing these procedures. I think there are also avenues just within your facility, people you can report to, and also the professional associations. Because like one problem the medical council always faces is that no one ever reports, like officially. So it's difficult to discipline someone when an official complaint has not been made. So also through associations, that can be another avenue that people can use.
Okay. Thank you for opening up more areas where people can actually go and report this. I think majority of us were not aware about them. There's a question here regarding lessons learned. Any lessons that we can draw from communities where FGM has reduced significantly Has it given you enough crucial insights, and what are the insights?
Dr. Kimani, I think that's the question we asked. What's the story for Central Region that needs to be learned for the other region? Because I think you've been doing a lot of work around that space. But maybe from where I sit, it may not be lessons learned from FGM, but anything that is a cultural practice, you cannot uproot it in the community without the community gatekeepers being part of it. And this is an example with the male circumcision in the Nyanza region with the communities that were not traditionally circumcising. And we've had successful stories in this country where communities' cultural practices have been shifted to align to the evidence and the science that is there of the time through embracing the community gatekeepers, the elders, and so that they are part of it rather than a cat and mouse game. So one of the critical things that we are reflecting now as the multi-agency team is how best have we really embraced and sat down with the communities on the ground to really understand the genesis of this Anti-FGM Act and really agreeing to the science that we have and understanding the logic behind the FGM and finding a best way forward that is not a cat and mouse as what we are seeing, where communities now shift to where they cannot be caught rather than abandoning something. So embracing communities and working with them based on experience with the circumcision is something that we are now increasingly seeing working with elders. And I think then there have been some declarations from elders, and there's one that is coming on specific communities, sitting with them and discussing and having their own declaration of how they view a solution to the FGM rather than bringing it as an external solution.
Yes, thank you.
I think
I can't agree more with Dr. Rose. I think one of the strategies and lesson learned is what you call stakeholder engagement and dialogues. And I think that is key. And this involves stakeholders like the communities, they need to be engaged, the cultural custodian, they need to be engaged so that they see sense and so that even the vacuum that is going to be created so that they can come up with a solution on how to fill that vacuum. We have seen that work in some of the counties like Ikuria and West Pokot. So stakeholder engagement and dialogue. And I think even for us, for medicalization, this is what one of the approaches we want to apply so that we can involve the health professionals through the association and the regulatory bodies, because these are not bodies that survive in vacuum. They represent the people in those bodies are actually healthcare providers. So when we engage them, then we are going to get a solution out of it. The second thing is integration. I think there is need for integration. So FGM is not going to be addressed as a standalone project. If we go by addressing it as a standalone program, then we are going to fail miserably. So we need to integrate this with the development projects. We need to integrate it in the health system. We need to put it under other programs that are already working, like immunization, hygiene, and maternal child. And that way, we can be able to maximize on the resources and the synergies that are there. The third thing is there is need for people to, data is very important. How we can be able to generate data and be able to share this data and learn from it. Very important, because we have very, very interesting data, but if the communities themselves don't know that this data can mean anything to them, or even the healthcare providers, if they don't know this data can mean anything to them, then they're not going to participate in this, in generating the data. So we need that learning and teaching each other about what this data means and moving forward so that we can be able to work together. I think that is what I would say. But generally, we also know that FGM as a cultural practice is also linked to other development issues. And one of the development issues is women empowerment and education and poverty and addressing poverty. This, especially in communities that are in far-reach areas, if you address issues of girl education, boy education, you reduce the poverty, these numbers start to go up and I think start to go down. And I think this is one of the things we have seen with the central province, with education and modernization and urbanization, the practice started to go down. However, that model can only apply to a specific communities. Like West Pokot, we have seen this. We have seen it in West Valley. We have seen it in Kuria. In the Kisii County, this model doesn't look like it can work. And that is why medicalization needs to be addressed from another perspective. Thank you.
I think, Dr. Kimani, what you've not added is our conversation that not one size fits all. And as you rightly put it, what may work in one community may not work in another, and the real need to take the community in its context, so that the Somali, we really look at them within their context, whether it's their religious or whatever beliefs. And the case is really understanding, because I hear from your research, the patterns and the reasons and the science behind what they do is quite very different, even though the act may be the same.
I totally agree. In fact, that is true. If you compare and the Kisii and the Abu Ghusi and the Kuria are very near each other, you will find that the dynamics are very different. Kisii, the levels of education are very high. People are, the socioeconomic people have a lot of money. Urbanization is quite high, but the practice is up there. You go to Kuria, it's the opposite, you know, and that is what Dr. Rose is saying. I think therefore you need more targeted interventions. Thank you.
Yeah, thank you. I totally agree. People do it for different reasons, so you
maybe my comment would be, oh sorry, I think
it's
just
okay.
my comment would be that the person who asked about FGM in different communities, like what Dr. Kimani has said, there are different drivers. It could be religion, just a culture. In some communities, if you introduce like male involvement, it brings the numbers down. In some communities, you use an approach of a human rights violation, it also brings the numbers down. If you bring children's rights violations, you know, so each community has to be looked at individually, and then you discover what the driver is in that particular community and then address that.
Yeah, customizing the solution is the best way. There's a question. Okay, it's rather like a scenario, especially on the medicalization of FGM. I was once faced with a situation where a husband refused to take his wife home after opening the cart for ease of delivery. What is a health personnel supposed to do in such a situation? I think this is a scenario of many medical people, and this is the best forum to answer that. Any of the panelists? Have you personally, like Dr. Ruth, have you personally had such encounters? What was your solution? How did you tackle such, if you don't mind?
It's a very good question. But
what was the question again?
So basically,
if you've had a patient who wants reinfibulation.
No, actually,
like if you have a,
yeah. So basically, a woman went to give birth. You cut them, you open them because of ease of delivery, and then their partner is refusing to take them home. It's bringing a conflict in their marriage and what have you. What do you do in such a scenario? Do you sew them up, or do you leave it at that? What happens? Because it's a situation, I feel like it happens to a lot of medical personnel, especially when they're delivering people who have undergone the stage 4 or 3. Yeah.
Okay, so we consider restitching back up like the labias is a reinfibulation, and that is a type of FGM, and it is considered illegal. So I would reassure the patient, but okay, maybe also this would be a good opportunity to, to educate them on the complications of the FGM, and then proceed to do what is medically right. Like if it's a repair of episiotomy or other tears that have occurred maybe due to delivery, but it is not right for a medical person to restitch back the labia. So that I would discourage.
Thank
I
you.
would
Thank you,
not
Dr. Ruth.
actually put them back together.
Thank you, Dr. Ruth. And I think part of the training materials that we have is, and you're right, that is the common thing that most healthcare workers are experiencing in the health facilities, not just the husband refusing, but even the women refusing to go back home, saying they want to be restitched back because if they go back open, the husband will get a new wife, he'll move away. So one of the things, and I think Dr. Kimani can chime on this, is when we were developing the materials is to look at experiences from other conditions that would cause a situation of gender-based conversation between a husband and a wife, and maybe learn from HIV where ANC HIV testing is done. If the woman is positive, there's sufficient time to have conversations around managing the situation. And so the FGM conversation going back to ANC, so that, you know, it's part of the conversation that you have with this woman in terms of what is the care, and she can ask all the question in a space where it's not an emergency. So like moving it backwards rather than making it an emergency. And then for those who then come within a situation of emergency, as Dr. Ruth rightly said, we still remember that it's not like you're being unfair for not restitching her. It's not good for her that you're restitching her. And so having that position of trust and working with this woman and explaining to her, hopefully she's able to see your situation and providing other options for her rather than doing an illegal thing that is not even helpful to the woman. But really the solution, if I would say, lies in us starting these conversations early, and even maybe having the partner much earlier in ANC to know what to expect during delivery. If you have examined this woman, you know that in labor this would happen, and explaining to them what solutions will be given may be a better option than just us being indifferent during ANC.
Yeah.
Just to reaffirm what Dr. Wafula has said, is that actually there's actually a manual which was there, which is what we studied about antenatal birth preparedness and even complication readiness for women who have actually undergone FGM. So, like what she's saying, this is you're in a hotspot of FGM. Ideally, you should, like what she said, start the conversation early. There's actually a checklist you should follow, and even some of these women, after they deliver, don't even know that. Okay, first of all, they should maybe expect an episiotomy to increase the space in the birth passage, and they don't even know that. And then it also changes. Like maybe after delivery, their mode of how they pass urine is going to change because now the opening is open. So it's a process. So I would actually, we were talking actually with Dr. Wafula today that they need to include the antenatal component there, because then you educate the woman throughout, first of all, in terms of complications that may happen, and then that way you prepare for birth, and in terms of birth plans, and then it's also an opportunity now to educate the community, you see, and people, because people hold health workers in high esteem, it's a very, very good opportunity, which I actually think is currently being underutilized. You find as health workers ourselves, we don't even know how FGM looks. Maybe we don't understand its complications, so we don't pick it up even when the patients are with us. So it's a process. It's conflicting because of the social aspect and the cultural aspect, but I think our end goal should be to be able to eliminate and eradicate it. So let's not encourage participation.
Okay. Thank you.
I can't agree more with
Yes, Dr. Kimani. Continue.
Yes, I can't agree more. I think they have presented that very well. I think it leads to education here comes in, and it is both for the women and also for men. Remember, like in a community, if you're brought up in a community where the cutting takes place, you actually think that is the normal, the normal situation that you should be in. But until you go to another community where the practice doesn't happen, you start to realize that you are the odd one out. I think, therefore, education needs to be sensitization, and education needs to be purposing to all people. Thank you.
Thank you, Daktari. And I also cannot agree more. The antenatal part, whereby we actually map out the women who have undergone FGM. We can actively ask and probably start having sessions on after delivery, this is what is expected, this is what is normal. I think it will go a long way, especially in asking for the restitching back. There's
and one of the strategies we have when we talked about integration of FGM into the ongoing programs in the Ministry of Health, we actually agreeing that FGM messaging need to be incorporated in antenatal, just like the way you do nutrition, you do hygiene, you talk to women about the expectation about childbirth and everything else. If that happens, then some of the issues that we are talking here will be resolved quite early and without any issues. Yep.
Yeah, and I think the best pilot county to start it with is Northeastern and Kisii. So maybe we can pick up the discussions, and especially with parties of those particular counties. And a lot of comments are regarding the rural areas where we need to do more there. And I believe this is the easiest and quickest win in terms of implementing it, in terms of starting it up in rural areas where we have this discussion from the antenatal to the end. There's for the last question of the session today, we have so many unanswered questions, and apologies for that. There's a video that has been going around showing men doing how the process of FGM is being done and what's being done on the women. And a lot of the men who came out were crying and they were very empathetic. I don't know, what are your comments or what are your thoughts on that particular strategy?
My take is I would comment from two aspects. If you are showing this video to a healthcare provider, it is okay, because this is what they're used to do. And probably maybe it could be educative and it could empower them more to understand what FGM is, and they can be able to pass these messages to the rest of the community. If you are sharing this with a community, you need to be careful, because there's a concept of the do no harm, which keeps on coming, because you need to ask yourself, what am I doing by showing this video? Am I likely to cause more harm? Or maybe what am I likely to achieve? My take is, if you show this to especially women and girls, this can trigger memories, and it can be really hurting to them, and it could be like a second FGM to them. For the men, I still think you may need to do some balancing on what you want to achieve, so that you also don't cause a lot more problems than you did. We did this quite some time, but we came also to realize it was also causing a lot of problems to them. When we were training some men in Nakuru, most of them will watch that video for 1 minute, and then they will start getting out of the room, and we thought it was traumatizing to them. Yep, that's my comment.
Yeah, thank you. Maybe just final comments to wrap up the whole session. We are way above schedule. From all panelists. Can we start with Dr. Ruth?
Maybe I can comment, and then Dr. Kimani can comment last, because it was his presentation. I think as medical providers, we have to play our part. Remember, we are trying to achieve the SDGs, and FGM falls under SDG 5, and particularly 5.3, where we target to eliminate all harmful traditional practices, including female genital mutilation by 2030. As health workers, we are aware and we have evidence. We're the ones with the knowledge and the science about the complications of female genital mutilation. And we are a sector that communities trust, to do the right thing, to do no harm, and to pass them the correct information. So we are a very valuable resource in the fight against FGM. And I'd like to ask us to all play our part
We have been entrusted with that responsibility of taking care of people, and we should play our part in protecting their rights and enhancing their health. So for me, that would be my parting shot. And as a member of COGS, we ask that anywhere you feel we can help participate, please invite us, and we will willingly do so. Thank you.
Thank you. Dr. Rose?
Thank you for the session. We are very grateful to KNH and Dr. Kimani Aka for joining us. I think this is a journey we have started. As a Ministry of Health, we definitely are taking this to the next level in line with the government of the day, the presidential directive, but also the law of the land. So we want to call upon our colleagues within the Ministry of Health, practitioners, professional associations and organizations, that we may push this message forward. We are happy that COGS is on board. We know that the other associations are also on board. This is just the beginning. We are very positive that with the comments and the feedback we are getting, we are headed somewhere. We'll definitely go to whatever length it will take to protect these women, girls from FGM, to align to the presidential directive and to accelerate their health in whichever way we can. So we are grateful for this session. We do have a TWG where we work and a COE where we work with Dr. Kimani and the COGS teams and the rest. And we want to call upon everyone who would like to join in this movement. Please join us at the Ministry of Health, Division of Reproductive and Maternal Health, where this is happening. We also have multi-sectoral platforms, and we are happy to work with you as we move this forward. My colleague is on the line, and I hope you don't forget her. She's the program officer for also this program, Mary. I know she's been silent. I would allow her to probably say something before Dr. Kimani.
Thank you, Dr. Rose. I've been on and off because of internet issues and power outage on my side, but I know that we have made it clear as a Ministry of Health that FGM can never be safe, even if it is performed by a healthcare provider. And medicalization is the health sector. Our main mandate is on the part of medicalization, to end medicalization. I know it's a multi-sectoral approach, and I know the efforts mainly are led by the Anti-FGM board. But if the health sector, we can play our part to end medicalization, and as we are committed to the presidential decree or commitment of ending FGM by 2022, if we can do that on our part, and everyone else, be it the government or the non-government actors, I think we will get somewhere. I'm glad that we are able to have such a forum where we discuss such an issue. In the past, we haven't brought so many people on board, but as Dr. Rose is saying, we encourage as many actors as possible to join us even on our technical working group or the committee of expert meetings, so that together we can harness our efforts towards eradicating the harmful practice. I will be happy to present what I was not able to present today because of time on intimate partner violence later on, maybe next week. Thank you very much.
Thank you, Mary. Our last comments from Dr. Kimani.
Thank you very much, participants and my panel colleagues. Mine is to re-emphasize that we are duty bearers as healthcare providers, and we have a duty of care to prevent, to protect, and care for girls and women at risk of FGM. And we cannot we can do this better by being proactive. I think for a long time the Ministry of Health has played a catch-up, and I'm happy that already, of course, it signifies the composition of the Minister of Health, very brainy people, very capable and very skillful. We have been able to catch up and we are doing very well. So let's keep them on momentum, and we continue protecting girls and women from this harmful practice. I thank you very much.
Thank you. As a parting, we're going to have the session of IPV by Mary in next week, or I think 2 weeks from now. Tune in for the other sessions. This week is Patient Engagement Week. It's a new field in medicine, focusing on quality healthcare. Please join in so that we can learn a lot. We'll be able to do more patient-focused care, because we have forgotten that side of medicine. Thank you very much for joining in, and thank you again, the panelists, for your very informative session. Kwaherini. Good night.
Kwaheri nawe. Good night.
Thank you and goodbye.
Good night.
Good
Good
night.
night.